Good morning, everyone. This is Brian Martin, Vice President of Medical Affairs here at UPMC Children's Hospital of Pittsburgh. And it's my pleasure to welcome you to this morning's Pediatric Grand Rounds, The Roads of Safety Culture and Patient Safety. Do they cross? Our talk today will be presented by Dr. Paul Phrampus. Dr. Phrampus is the Medical Director for Patient Safety of the UPMC Health System, and is also the director for the Weiser Institute here at UPMC, with extensive experience in simulation education and advancing the state of the art of simulation, both here at UPMC and also educating literally across the globe. He's the past president and current fellow of the Society for Simulation in Healthcare, and he's also a practicing emergency physician over at UPMC Presby and a certified professional in patient safety. This morning, Dr. Phrampus is going to be speaking with us about the culture of safety, which is broadly defined as the extent to which safety is emphasized formally and informally within an organization and all of its members. He's going to review the concepts of safety culture as a core foundation and foundational principle for how we take care of our patients, as well as the importance of a high reliability organization. And he's looking to engage all of us to be thoughtful contributors here today in terms of what our roles are for our culture of patient safety here at UPMC Children's and also across healthcare. We're looking forward to joining Dr. Phrampus with this presentation. And with that, Paul, I'll hand it over to you. Thank you very much.
Great. Thanks very much for that introduction, Brian, and I'm glad to be here this morning to deliver this presentation a year later than scheduled, by the way. I think we had this on the books for about a year ago, and that's when dramatic shifts happened that required some rescheduling and reprioritization. So nonetheless, I'm here to do it this morning, and I've updated the presentation to reflect some more current literature and look forward to getting started. So I want to talk, as Dr. Martin mentioned, about safety culture as well as actual patient safety. I want to give some ideas and thoughts on the scope of patient safety issues and problems on the national landscape as well as locally, and talk some of the foundational kinds of things that probably contribute to our ability to deliver safer and high quality care, which is sort of the goal of all of us practicing in healthcare today. So thanks again for this introduction, and look forward to this as well as the chat and the questions and answers that will be conducted at the end of this. I kind of have a brief overview of where we're going to go, talking a little bit about high reliability organizations, and then just a few words on safety culture, and then tying together the two of patient safety as well as safety culture, and thinking about how where the elements of importance are and what we can do as practicing clinicians and advanced practice providers to move the needle forward and improve the safety of patients and overall deliver better quality care. As you may know, the patient safety issue has reached the popular press in a lot of perspectives in the last few years. Some of you may have seen the data and the news releases espousing that patient safety issues and medical error is the third leading cause of death in the United States. This particular study was a culmination of a number of epidemiologic studies that were brought together and in fact underwent some scrutiny, and some people that were claiming some cases were inadvertently and improperly added and some were excluded and so on. But I like to just bring it back down to this perspective and say, you know, this number is 250,000 people a year dying from medical errors. And even if we have that wrong by a magnitude, it's 25,000 at the bare minimum. So I think that nonetheless, whether it's 250,000 or 25,000, either of those numbers is wildly unsuccessful in today's healthcare practice, and we need to address it, rather urgently. Some epidemiologic studies that were done back in the early part of the decade and found that 1 in 3 hospitalized patients experience adverse events, and 6% of those cases, the adverse event that touched the patient was severe enough to prolong the patient's hospitalization or let the patient go home with a permanent or temporary disability or death. So 1 in 3 hospitalized patients, and then 6%. If you think about the hundreds of thousands of people across the UPMC health system that we admit to the hospital every year, they fall into this category, and it becomes a very scary proposition to undergo and receive healthcare, basically. So that's fine. That's some global data, some epidemiologic data. Let's talk about UPMC. Across UPMC, our numbers locally, that's you and I, have 20 serious events per week on average. And I just take my word for it. A serious event is basically some kind of event that hits the patient that was not supposed to, that caused significant harm. I'm not going to get into the details of what a regulatory definition of a serious event is, but suffice it to say, it's not a near miss. It's not a simple little problem that we corrected and moved on. A serious event is something that caused something to the patient that was serious. For example, extending the hospitalization, unplanned return to the operating room, operating on the wrong side of the patient, inadvertent death from patient care. Those are the kinds of things that fall into this category of serious events. So it's important to also recognize throughout this entire talk, and whenever we talk about patient safety, that we're talking about the things that we know about. And so that is in terms of how do we know what is reportable and what is reported. And it's important that we recognize that there's probably a whole lot of things that are unrecognized and unreported in the system. And I think that many of us in clinical practice kind of know that that possibility very much exists on the day-to-day basis. So a little bit of trivia here. This is James Reason, and that's a hunk of Swiss cheese. And I wonder if anybody knows what the significance of James Reason and the Swiss cheese is. Whoops, move back. I gave away the answer already. James Reason is a sociologist from Scotland, and he focused his whole career on safety. And early in the late 1990s, he focused a lot of ideas on patient safety from an organizational perspective and applied it to healthcare. And he came up with this idea of the Swiss cheese model. The Swiss cheese model sort of looks like this. There's a red line. This red arrow depicts harm on the way to hit the patient. And each one of these slices of the cheese is something from a patient safety perspective excuse me, that we have put in place in a systematic way to stop that red arrow from hitting the harm. So what does that mean in a granular way? Well, it might mean our staffing policies and how many people does it take to do what. It might have to do with the overall policies and how do we do things, like how do we verify the right person is getting the right medication at the right time. It might drive equipment decisions, and it might drive some of our training, some of our orientation, some of our new hire onboarding kind of things. And each one of these systematic implementations in the safety perspective is supposed to either shrink the size of the hole or actually move the hole in the Swiss cheese somewhere else so that there is a deflection of this arrow once the systematic barrier to harm hitting the patient is successfully sort of thwarted. So we think about patient safety when we think about safety culture and high achievements in safety, we always talk about high reliability organizations. And I like to talk about this and contrast it to the healthcare environment. So some definition or defining properties of high reliability organizations are here. They're complex, internally dynamic, intermittently, intensely interactive. So just take 15 seconds. Does that sound like where you work? Complex, internally dynamic, intermittently, intensely interactive? I think the answer, no matter where you work across the delivery of healthcare, you have to say yes. All right. So the next question or next defining piece of high reliability organizations are they perform exacting tasks under considerable time pressure. So does that sound like where you work? Almost definitely. If you're on the front lines of delivering healthcare, exacting tasks under considerable time pressure is what we do each and every day for all of the patients that we serve. Here's the third thing about high reliability organizations. They carry out these demanding activities with low incident rates and almost complete absence of catastrophic failures over several years. Does that sound like where you work? It might at your unit level, but it certainly is not at the systematic level or even at the hospital level. And I'm not talking about just UPMC, I'm talking about the healthcare delivery system that's across the United States. This is where we deviate from the high reliability organizations. We still haven't been able to nail it like other high reliability organizations, such as the airline industry, such as the nuclear power industry, and other industries where it is exceptionally uncommon by the numbers to hear of catastrophic failures over several years. So I want to focus a little bit on how do we get there? How do they get there? High reliability organizations have a number of characteristics that are defined by reason and others. There's a preoccupation with failure. The acknowledgement that what the organization is putting forward is high risk and that things have to go exactly right to make it happen without failure. A commitment to resilience or bouncing back once there is some sort of threat or failure. A sensitivity to operations so that the leadership of the organization is in touch and in tune with and attentive to what the issues are that are being faced at the front line by healthcare providers in our case. A culture of safety, which we're going to talk a lot about here. This is the attention to how people perceive safety, and I'll get back to that in just a minute. And then I'm going to say a few words on a just culture, and that is a culture of fairness in response to incidents. So let's focus on that last piece for a second, the culture. Culture is defined as predominating attitudes, beliefs, and behaviors that are characteristics of the functioning of a group or organization. So it's sort of the how we do it, how we think about each other, and how we think about things. That's what culture is. Safety culture, as mentioned in the introduction, is the extent to which the safety is emphasized, both formally and informally, by an organization and all of its members. And I've picked some constituents to represent up here on the screen at the moment. In your upper left is practicing healthcare providers. That's kind of a no-brainer as it comes to safety culture. But some of the other things might be a little bit obscure. Up on the right is patients. Do patients have a role to play in patient safety? Do family members have a role to play in patient safety? And I argue that they do. They, in fact, have a very, very important role. And it is up to us as the healthcare providers, but us as the system to engage them in a way that they are equal and actively participating participants in the safety of the loved one that's receiving the care. And then the bottom one is the boardroom, the leadership. And we're going to focus a little bit, actually, we're going to focus a lot more on the importance of the leadership and how that should factor into creating a safe system for delivery of healthcare as well as the safety culture. And this is a kind of a, I'll say, relatively new mandate that I'll talk a little bit more about in a second. So in Reason's work that has been around for over 20 years now, he lists a number of foundational principles to have a adequate or to have an active safety culture that reduces errors. And three of those foundational pieces are a just culture. We'll talk more on that in a little while. A reporting culture, and that is one where people feel comfortable to report what didn't go well or what almost didn't go well vis-a-vis a near miss, as well as a learning culture. And a learning culture means that we have investigated what didn't go well or those near misses. We have properly assessed or figured out what caused it, and that we share that learning across the organization. We change our policies, change our procedures, change whatever we need to do to make sure same or similar errors doesn't come to the patients that will receive care into the future. So the potential impact of safety culture is far-reaching. They can have impacts on our hacks and PSIs, and pardon the safety deep lingo here, but we're talking about hospital-acquired conditions or things that happen to patients when they come in the hospital that shouldn't. Patient safety indicators I'll get back to, but they're basically just bad things, as you could well imagine. Other areas of potential impact for improving the culture of safety that have been shown and are evidence-based are decreases in the severity as well as frequency of risk management claims, the reduction in serious events, those bad things that I was talking about earlier that hit patients, medication errors. Half of the medical errors that are reported around the globe are medication errors. Okay, so a significant number. And then recent data and recent studies have definitely shown relationships between the safety culture as well as employee engagement and retention, satisfaction, job satisfaction. The higher the overall measured satisfaction of one job is, correlates directly to safety cultures, and vice versa. Places that have safety cultures or significant amounts of patient safety problems generally find an inverse relationship to employee or workforce satisfaction, I should say. And then lastly is patient satisfaction. Obviously, when errors occur, whether they are minor or major, they are an extremely unpleasant situation, unfortunate situation, and definitely impact patient satisfaction, who, you know, from the patient perspective, when they come into the healthcare system, they just make the assumption that everything is going to be done safely and perfectly, and we have to live up to that. So this safety culture thing, can we measure it? And the answer is yes, we can. And many of you have contributed to this in the past. In fact, we're required by some regulatory issues to measure the safety culture, and that is through, we at UPMC use the AHRQ, the Agency for Healthcare Research and Quality. They have a safety culture called the Culture of Safety survey, and that's the instrument that we use. And many of you have either done the full survey in the past, or we've taken an abbreviated set of questions and put them into the My Voice survey in recent years, and we intend to do full culture of safety surveys every several years. So when we look at measurements of key culture of safety, there's a great study. It's getting old now, from 2010, but it's the biggest one of its type. And that is one that looked at 15 different domains of patient safety culture measurements, crossed it with patient safety indicators that I'll show you some examples in the past. And it was performed across 179 hospitals of various types: big hospitals, small hospitals, teaching hospitals, non-teaching hospitals. Because I think this study is important and relevant, because when people are trying to justify away investment in safety, they say that doesn't happen in my hospital. My hospital is different because we're big, because we're small, because we're teaching, because we're non-teaching, etc. So this is looking at 179 hospitals. Patient safety indicators. I don't want to go over all of these and bore you with this, but I want to show you. Sorry, this is examples of the domains of patient safety that you answered questions previously on culture of safety for. It's things like communications openness, feedback and communications to error, the frequency of event reports, how the perception of handoff and transition is, non-punitive responses to error that we'll talk a lot about here in a few minutes. So you get the idea. It's different areas that are surveyed and sampled that make up the composite score of the culture of safety. The patient safety indicators that I mentioned before that were utilized in this study are here on the screen. And again, I don't want to go through these line by line, but I want to show you some examples. Iatrogenic pneumothorax, postoperative hemorrhage or hematoma, postoperative respiratory failure, postoperative sepsis. And the short story is, why was this list chosen from a big, long list of patient safety indicators? The answer is because they were easy to measure, and they were thought to be relatively accurate. That's another issue that we have in the safety world, is sort of the denominator as well as all of the data, and knowing what to be confident about and where there might be some role for interpretation. So they picked these particular patient safety indicators for this study. What they found is that there was a correlation with the culture of safety as measured by that culture of safety survey that I was talking about, along with the amount of those serious events that I was mentioning earlier. So there was a correlation that showed that places with higher safety culture had less safety incidents. Big hospitals, small hospitals, teaching hospitals, non-teaching hospitals, all brought into this study. So one of the, we'll say, founding fathers of the modern movement of patient safety is a former surgeon, retired surgeon from Tufts, his name is Lucian Leap, and he founded a number of significantly important patient safety organizations across the country. And Dr. Leap said, management must manage for patient safety just as they manage for efficiency and profit maximization. Does that sound like where you work? I hope so. Safety must become part of what a hospital or healthcare organization prides itself on. Okay, so he was talking about this from a moral and ethical challenge, and more recently, as the VPMAs that have been at some of the VPMA retreats have learned from some outside speakers that we've brought in, there's a business case for safety also, which is important to know, and I'm going to talk a little bit more about that at the end. But management leadership must manage for patient safety just as much as they manage for efficiency and profit maximization. I want you to continue to think about that through the rest of the talk. Recently, 2017, the Joint Commission issued a Sentinel event. So the Joint Commission finds things that are of paramount importance to influencing the safety of patients getting care across the country. And then when they find one thing that they say, this is so important, we have to put together a report and issue it out. That's what a Sentinel event alert is. And this one came out in 2017, and it is entitled The Essential Role of Leadership in Developing a Safety Culture. Okay, so it's critically important that leadership is engaged and they are active, just like Dr. Leap said about 20 years ago, in this formation of safety culture and safety systems that help to improve the safety and care of patients. If you read further down in this report, it talks about inadequate leadership can contribute to adverse events in various ways. Look at this, including but not limited to insufficient support of patient safety event reporting, lack of feedback or response to staff or others who report safety vulnerabilities, allowing intimidation of staff who report events. Think about that. I know there's somebody watching this video that probably suffered from that. Either real or imagined, but the perception is in the eye of the beholder here. Refusing to consistently prioritize and implement safety recommendations and not addressing staff burnout. This was part of the Joint Commission's call to arms to leadership in 2017 that said, if leadership is not engaged in this, you are leaving patients vulnerable. And here are some of the examples that we think that you need to be engaging in. So another aspect of safety culture is a punitive piece that we talked about earlier. And Dr. Leap testified before Congress, I think this was in 1999, maybe 2000, and said that the single biggest problem in the medical industry is that we punish people for making mistakes, okay? We punish people for making mistakes because what we know is a punitive culture that comes from that creates fear, destroys creativity, builds barriers, and drives errors underground. Remember what I was talking about earlier with those events that happen that are never reported, that nobody knows about, and patients get harmed and we don't even know. It doesn't even come across our radar screen. This is a result of a underdeveloped safety culture, I guess would be the best way to say it, that allows these things to permeate throughout. Now, what does this mean? Does this mean that everybody that creates an error all the time should get off scot-free? No, that's not what we're talking about here. But what we're talking about here is an error that occurs shouldn't automatically result in some sort of punitive action. And this is something that we still have a lot of work to do to undo across our system, as well as systematically across the healthcare delivery system in the nation. And I'm going to give you some more examples of that in a few minutes. James Reason said a long, long time ago that blaming individuals is emotionally more satisfying than targeting institutions. And this is so true today. It is so much easier to say, this is a failure of that nurse, this is a failure of that physician, this is a failure of that nurse practitioner, as opposed to managers and leaders making sure that the question was asked, how as a leader, how was I able to put the person in that practice environment that allowed that harm to occur to the patient? Dramatically different question than saying, how did he or she screw up? But the easy way is to say, wow, he or she is normally great, but this time they really blew it. As opposed, and it's kind of shirking responsibilities to what the leadership and the management should say. But I don't know a single nurse manager of a unit that wants to say, this happened on my watch, and come forth and say, I don't know why, but I am committed to fix it. Okay, that's a big pill to swallow. Same thing on the physician side, same thing on the pharmacy side. When I give these examples of different practicing domains, I'm not picking on anyone. Trust me, it's ubiquitous across the practice of healthcare delivery. So I've given you a lot so far. I want everybody to take about 60 seconds here and just take a break and close your eyes, go to your happy place, and think about whatever you like to think about. And I'm going to be back in 1 minute. Welcome back. Seems like forever, doesn't it? A minute in your day. Well, there's about 1,440 of them. And I would offer up that we don't do that enough. We don't take those mental breathers in the middle of a clinical shift. Can we afford a minute? I think most of us can. close our eyes, just kind of de-stress, clear the mind a little bit, and be able to be focused and attentive back to your patient's needs as you move forward. Think about that. So let's talk about safety culture and talk about it here locally at UPMC. Let's focus a little bit on the punitive culture, and this makes some people squirm, but I think it's an important thing to talk about. So a few years ago, when we did our last large-scale full measurement of the patient safety survey, we found this. There's a question that asks respondents to respond to the statement, UPMC fosters a non-punitive response rate, or non-punitive response to error. 72% of people in practice of healthcare disagreed with that statement. Only 28% agreed. So it's an area that we've been working on for a number of years, and I'll talk about some of those efforts in a few minutes. But suffice it to say, we haven't moved the needle very much on that in recent surveys, and it's an area that managers and leaders really need to focus and think about, along with the caveats that I'll share with you. This is an article from 2011 that was in the Pittsburgh Post-Gazette. And I want you to think about this. I want you to think about this in the context of you're driving to work, getting ready to do your daily routine, whatever that is in terms of the practice of healthcare. And you hear this news article, or somebody reads this article to you in the paper. Hopefully you're not reading the paper while you're driving. It's a whole separate issue. Entire UPMC transplant team misses hepatitis alert. And it goes on to the details and the details of it. So this is public facing. This is public facing information. And then you keep reading and it says, it is still unclear if the recipient contracted the disease. They were talking about the patient. But then they said, but the medical error led UPMC to demote a surgeon and suspend a nurse 2 weeks after the error was first discovered, and went on to say the fate of the physician involved in these descriptive titles, and it was taken off the website, and so on and so forth. Now, you're the healthcare provider that is driving to work, and you hear this story and you hear this response. How's that make you feel? How's that make you feel about the want to report an error, or the want to report an error about somebody you know, or report yourself for an error that occurred? Yeah, you're right. It's not going to happen. Okay. This is what a punitive culture and a punitive response to healthcare error looks like. And it weighs in the minds of people actively, consciously, subconsciously, and so on, and definitely affects the safety culture. And you end up with this punitive culture. And it's getting worse and worse, in my opinion, with social media and media sort of always looking for the gotcha part of the story so that they can sell more news, sell more ads, and so on and so forth. That these things just come out all the time, over and over again. And they weigh on people. They weigh on people in terms of worrying about, am I going to lose my license? Am I going to lose my job? Am I going to be suspended every single day when I go to work? Now, let me start off with one of my caveats. This is not talking about the person who makes repetitive errors, doesn't pay attention to details, comes to work with substance abuse issues, and makes errors. This is talking about just in the thousands of things that you do every day. One time you made a mistake, and perhaps it harmed a patient, perhaps not, but that mistake is uncovered, and the response to that mistake is punitive. Okay, that's what we need to move away from. If we look about how UPMC compares to the rest of the country, this was again from our last full survey in 2017. I'm not going to go over every domain, but I just want to show you. The orange bars represent the response of about 500,000 people in different healthcare environments that feed into this national database on culture and patient safety. The purple bars represent the aggregate data from 18,000 people across UPMC that responded, and the domains of safety are that bring up the safety culture score are across the bottom that I pointed out to you on a slide before. Okay, so what you can see is that UPMC lags behind the national 50 percentile in every single category. So we definitely have work to do in any category you want to pick for the safety culture. But what I do want to point out is we also lag behind in sorry. We also lag behind in this area here, which is the punitive response to error. But I also want to point out it's the lowest performing domain in the entire survey of 500,000 people. So we all have this problem nationally, and we need to continue to address it to make it more equitable and more fair and more transparent in terms of how errors are dealt with in the healthcare environment. How does leadership need to be involved? I already shared with you the Joint Commission Sentinel Event Directive, but leadership needs to engage. Leadership needs to understand that this culture is the iceberg part that is below the surface, which is far more substantial than the tactics or the strategies that are above the ground that might be created directly by the leadership in their current roles. There needs to be greater education of physicians and APPs and other healthcare providers about safety events. Those of you from the physician side have probably heard my patient safety call to physicians in the annual ULearn mandatory trainings, talking about physicians need to own this. Physicians and APPs need to understand that they are a driving force of the leadership of patient safety. Whether you think of yourself in a leadership role or not, patient safety resides with you. How you act, how you treat people, how you treat patients, and how you bring forth the attitudes of safety to the bedside. And many physicians in particular, I think, are unaware of their influence on the safety culture. This applies across the board, but I really want to call out physicians and APPs as the need to take the leadership in all of this. And it's not always this screaming person here that is the problem. Everybody knows who that is, this screaming doctor that's angry and mad and cursing at people and throwing things and those kinds of stories, okay? But it's this guy here rolling his eyes and just creating this passive aggressive environment towards safety that I think is even a more pervasive problem across the board with physicians, with APPs, but especially in the nursing world. This sort of passive aggressive activism is working hard against a healthy culture of safety. When somebody brings a concern to you as a physician or an APP, if you in any way roll your eyes or the equivalent sort of expression, you have significantly undermined the safety of all patients across UPMC. Other important things to engage leadership, there's a number of studies, I don't want to go into all of them for this broader audience, but definitely show impacts when leaders of the organization, as well as senior managers of the organization, do walk rounds and talk about safety and engage employees on the unit where they work about safety, understand what's going on the unit where people work about work and how it relates to safety and the overall impact on the patient safety culture that is measured at that organization. So moving forward and talking about some other issues insofar as how patient safety works is this. Humans are fallible and can make mistakes. In fact, I need to change that a little bit and say humans are fallible and will make mistakes. And this is inclusive of all humans, including physicians, and yes, even surgeons can make mistakes. They will make mistakes, okay? It is impossible as humans, this is sort of our a short-circuiting of how we're wired. And for us to do repetitive things over and over and over and over and over again without fail doesn't happen. And the importance of that statement is that we can't expect for that to happen. We have to design systems around this weak link in the system that says humans are fallible. Humans are also the strongest link in the system in other ways in terms of recognizing when things aren't quite right and interpreting, something that is just a little bit off. We can do that far better than machines. But this repetitive tasking without error, no matter what happens, no matter how tired we are, no matter how many patients we've seen this day, no matter where we are on our cycle of sleep and rest and all those kinds of things, we are vulnerable to make mistakes. So that brings us to just culture. Just culture used to get a bad rap because when it was talked about a long time ago, when we first launched it at UPMC, we basically were using the terms blame-free, and that's not what just culture is. It is not blame-free. It is a balancing act of the blame versus punitive, or what is a better way to describe it is holding people accountable for what is to be done and holding the system accountable for what is to be done. So it's not just get out of jail free card for everybody every time they make an error. That's not what we're talking about. We're talking about global accountability as it relates to your professional responsibilities in the delivery of healthcare and balancing that against a punitive state. So that's how the Just Culture algorithm was adopted here across UPMC. And I'm just going to kind of paraphrase a few things of the algorithm. Those of you in the management and leadership ranks, we are getting ready to launch a new wave of Just Culture training that will be coming out, I think we're going to start in July, that we've been working collaboratively across the system to develop. But the short story of Just Culture in a healthy environment is this. It sort of says error occurred. Let's just say harm hit the patient. Did the person intend to cause harm? Usually that's no. Did the person come to work drunk or equally impaired? Hopefully, and usually that's no. So then we get into the more tedious interpretation pieces. Did the person knowingly and unreasonably increase risk? Maybe the most important question is, would another similarly trained and skilled person in the same situation act in a similar manner? And this is known as Reason's substitution test. That goes back to James Reason, the Swiss cheese dude, okay? Because this is what we're talking about as workarounds. If policies and procedures don't make sense sometimes, they don't match clinical practice sometimes, particularly Saturday night at 2 a.m. when there's a different staffing, different setup, a different availability of resources than there may have been a Wednesday at 1 p.m. when these policies and procedures were designed around. Workarounds occur, okay? If a nursing unit is working short-staffed, workarounds occur, okay? And so what this is saying is the person that made this mistake, if 2 or 3 other people in the same situation, in the same environment, could likely have made the same mistake, then this is a system issue. It is not a person issue. It is not something that should be dealt with a punitive response. That's the substitution test. I'm not going to get into the nuances of the rest, but you get the idea that there is a fair and equitable process and an algorithm to be applied to each and every error. And all members of the organization become comfortable with the fact that if they make an error, they will be judged in the same way as everybody else in this transparent fashion that holds equal accountability to the system. Because reiterating this idea, we cannot learn from mistakes shrouded in secrecy and defense. Our goals and vision across the system are to create a safe, fair, engaged culture that focuses on the elimination and prevention of harm elimination of preventable harm and death that comes to patients. I mentioned already 20 times per week, we are doing serious harm to patients across our system, not somewhere else, not a lesser place, not a small hospital, not a big hospital, not a teaching hospital, not a non-teaching hospital, at our hospitals 20 times per week. We want to eliminate unintentional patient harm, and tying together the aspects of this talk, you know that where some of those underlying tenets will come from, and that is in the way we report, the way we investigate, the way we review, the way we try to build the safety culture. And what we want to do is transform UPMC into that learning culture to where we're taking the learning from what we didn't do so well and converting that into excellence into the future. Okay, everybody always wants to know about these incident reports, and actually at Children's, you guys have a very, very healthy reporting culture in terms of people putting things forward in Riskmaster, and your safety team is outstanding and one of the top ones in the system. But everybody likes to know what happens to all these incident reports that go in. So I kind of want to just review that really quickly and show you how it ties together with the rest of this plan. So an incident or near miss is reported. It's reviewed by your safety team, and they decide what type of investigation needs to go on. If it's something they already know about, or if it's an ongoing problem, there may or may not be a need for a big, deeper, multidisciplinary investigation, but oftentimes there is. And that deeper, big investigation is what's called a root cause analysis, or root causes analysis is what I like to say. That's the investigation. And in that investigation, if it's properly done, systems things will be evaluated first. System things like was the right equipment available, were the right resources available, what are the policies, what are the procedures, were they followed, and were they adequate to address the current situation? Then we look at the people pieces and how were the people involved were how they contributed to and either made worse, made better, or what the response was once the incident occurred. We oftentimes find issues of communications between different physicians, communications between physicians and other healthcare providers, domains, and divisions across the system. And when we find specific physician issues, and people issues, it needs to run through the just culture algorithm to figure out the appropriate approach and the appropriate way to deal with it. If it is physician-specific questionable behavior or practice, it goes into physician peer review. And this is set across separately because of state statutes and mandates that protect different information from disclosure into the litigation process. But the short story is all of this information culminates into actions to improve the local situation so that the same or similar errors can't happen again. But more importantly is if we push it out and we learn from it as a system and we sort of rise the tide of the entire system and convert into a learning system so that we are understanding what happened, why it happened, how we are going to stop it from happening again, and making sure that everybody is aware and that we spread this good word so that we can keep patients safer and improve the quality of healthcare. It's not always easy. I had this study from a long time ago, but it's the only one I've ever found that I think is really important. And this is important when you hear about an incident and you think about it and you're involved in processing an incident. When harm has occurred, our assessments of other people's behavior gets colored negatively by the outcome and the hindsight biases. One of the biggest problems that I still have when I deal with HR people, when I deal with other leaders is trying to get them to disconnect. The outcome of what happened to the patient is disconnected from what we should do about the error, okay? Because when people get seriously harmed or they die because of an error, there's this kind of piece that wants to find the person who did it and just kind of whack them. And blaming individuals is more emotionally satisfying than taking system responsibility, as James Reason taught us in the past. This was a good study from, was it 1991? 112 anesthesiologists reviewed 21 cases. Half of the anesthesiologists knew the outcome of the patient, the other half did not. They reviewed the 21 cases, and the short story is they were asked to render a judgment of whether appropriate care was delivered or not. Well, guess what happened? Okay, the half of the anesthesiologists that didn't know the outcome of the patient were oftentimes saying that, yes, the care was appropriate. The half that did know and knew that there was a terrible outcome of the patient overwhelmingly, more frequently said inadequate care has occurred. And they were reviewing the same cases, okay? There is an emotional connection that comes from harming patients or comes from the death of patients involved in error. But when we go back to the science of safety and how we're going to deal with this and how this feeds into our culture, we have to be careful to dissociate that as hard as it is from an emotional perspective to make things move forward. So what can we do? Talk about safety. We can report safety. We can remind each other about it. You know, in healthy safety cultures, we have each other's back. Encourage safe communications, practice, and consider team training. Team training is an interesting one. We know that it has potential impact on culture. We know it has impact on the safety culture. There's lots of literature that links teamwork training and to outcomes, to financial outcomes, and so on. There was a study, the last thing I'll talk about, that was done at the Ohio State University Health System a number of years ago. And the bottom line is they took everybody in the operating room, the perioperative service, about 3,000 health system employees, including physicians, nurses, nurse practitioner, nurse anesthetists, everybody involved in the operative and perioperative care, basically, and put them through teamwork training. And they mandated it. And they calculated all the costs, and it cost them $3.6 million to put this program on. That counted the time away from work, the amount to bring in the contractors to do the teaching, et cetera, et cetera, et cetera. The short story is after 3 years, they had a 26% reduction in their expected adverse events as compared to the 3 years prior to the training. Okay, and they used a cataloging of errors to cost to say that they saved between $12.6 and $28 million, depending on the conservativeness of the estimate of the harm and of the financial amount of the harm. So they concluded that the return on investment for team training, this was crew resource management is the type of training they use, CRM, save them $9 to $24 million after they paid that $3.6 million to fund the program. So this is a message to those of you interested in safety, interested in quality, and thinking about how can you find some resources, how can you find some finance to pay for these kinds of things. There is a business case for safety that needs to be looked into. There is a business case for quality that needs to be looked into. And through multidisciplinary partnerships with finance, with risk management, with different aspects of leadership and across domains that we have available at UPMC, we can help to recognize what these benefits may be. And more importantly than paying for our programs, we can improve the safety of patients and improve the quality of delivery of care. So I'll leave you with a request. If we're going to move the needle, I need each and every one of you to join me with a personal stake in safety. Develop your own preoccupation with failure. Understand that when we provide care to patients, 10 patients, 20 patients, 50 patients a day, when we do procedures on patients, when we write prescriptions for patients, it is very special. There's nothing routine about it. There needs to be a preoccupation with failure and think about how can this go wrong? And what am I doing to make sure or minimize the chance that something is going to go wrong? If you do this and practice this each and every day that you're caring for patients, you will influence your local culture. We want to have that idea of looking at each other's back or mutual appreciation for, is someone overloaded? Can I help them? Do they seem tired? Do we need to watch over them carefully, etc.? And then lastly, be emboldened to hold your leadership accountable. When things are not right on your unit, in your division, in your department, in your business unit, make sure you're sounding off in a respectful and appropriate kind of way, but bring leadership in. Remember that Joint Commission Sentinel event says leadership needs to take ownership of patient safety. Think of those words of Dr. Lee. Patient safety needs to be managed and led just like efficiencies and finance. So let's work together, hold the leaders accountable, improve patient safety across the system, and improve the quality of delivery of healthcare. With that, I'm going to stop, and I want to thank you for your time and attention this morning. And even though I'm here a year late, I'm really equally excited to be here, and I want to thank you, and I look forward to meeting with you in person and hopefully doing this talk again when we can all meet in person. Thanks a lot.
Thank you so much, Dr. Phrampus, for that excellent talk. We do have a question in the chat from Megan. How would you encourage the sharing of significant events or near misses across units and departments to improve transparency without appearing to place blame?
Yeah, that's a great question. I think you said it was a Megan that asked, there's a couple ways. One is that the sharing is done through your patient safety or your quality experts, and that they appropriately de-identify the situation. It gets difficult in small hospitals. It gets difficult when we're inside the conclave of a single hospital, when we know about the significance of the event. I think what is important is, especially in the big events, is that they are dissected down into the root causes. Then we can peel off and take some of those root causes and address them, disseminate that information without anybody realizing that it ties back to the bigger case. Now, that sounds a little subversive, but again, we also need to protect the person or persons that were involved in the area. So that de-identification process is significant. The other thing is sometimes a delay in the feedback and the delay of the reporting of the case can move forward. And then the other thing that can happen that can help protect the anonymity of the people involved as well as the case, depending on the type of case, is some of the details can be tweaked a little bit so that people don't realize the exact patient that the case happened to, but the learning from the case is disseminated across the board. I hope that helps.
Yes, thank you. We don't have any more questions in the chat right now, but I wanted to invite everyone to please join. Oh, we have one more. Perfect.
All right.
They're pouring in now. So Ms. Anita Weaver says, would you recommend that health and safety teams that are responsible for evaluating errors that occurred should not be aware of patient outcomes as a result of the error?
So in an ideal world, yeah, that's right. I hope I've made the case that firewalling off the outcomes will allow you to have a more pure investigative piece to it, or at least a determination of what the outcomes of the investigation should be. Because, when bad things happen to people, it really tugs at our hearts as healthcare providers, as leaders, and there's this natural tendency to want to place blame on the individual. And it's really, really tough to do that. So, if we could do that type of system, I would advocate for that fully. In fact, I have some ideas for the future for that, but I have to still do a bit of maturation work on those ideas.
Thank you. We have an anonymous question of, how do you frame questions to identify system issues rather than issues with individuals?
Yeah, so that's great. And make sure that my words are not mistaken. We do need to address the individual contributions to the errors too. It's just how much we balance what the individual did versus the environment that they were provided to conduct that practice in. That's the sweet spot of these investigation pieces. But part of it is trying to get to things that are objective. For instance, on the RCA report forms, it oftentimes says, was staffing an issue? And most of the time, leaders of business units or managers of business units just say no, okay? Because that's sort of a subjective question. There's a very subjective question. And if it's the leader of the business unit that is answering it, they oftentimes are reticent to say, yep, I let these people work short-staffed and this error occurred and that probably contributed. A better way of asking the question is finding an objective way. And the objective way to that same little scenario I just created for you is, this error occurred. How many people were scheduled to work and how many people were actually working? And then if you find a deficit or a significant discrepancy, then part of the answer is staffing probably played a role. So finding ways to objectively evaluate things is an important thing. The other thing is, along with that objectivity, is trying to firewall emotion. Okay, so you think about reason substitution tests. If I said, could 2 or 3 other nurses, if I'm, let's say, evaluating a nursing event, could 2 or 3 other nurses have made the same mistake? Let's ask a different unit director in a similar unit that question, not the unit director who is in charge of the unit where the error occurred. So that's another example of how to firewall off some of the subjectivity and emotional responses that come to these investigations. I see a question from Dr. Choi in the chat that I can see. Do you see that, Colleen?
Yes, we see that as well. We were going to ask that we address that question in the meet and greet because we're at the end of the time for our grand round session.
Got it. Great. Okay.
Thank you again so much
Thanks,
for your
everybody.
excellent talk. And the details for the meet and greet are in the chat for everyone who would like to join.